All right. The next talk we have is from Dr. Deepan Singh from the US, from the Maimonides, my apologies, Medical Centre. And Deepan is presenting, we all know of the poor side effect profile of a lot of antipsychotics, like risperidone, that are prescribed for irritability and aggression. And one of the most exciting reuses is the drug Guanfacine. So I'm really interested to see what potential Guanfacine might have as a target to treat irritability and aggression. Thanks.
Thank you so much. Thank you so much for having me in this beautiful country. My first time here in Australia. Can everybody hear me well in the back? I think the visuals are small from back there, but I'll try my best to sort of talk you through this. All right, so it's the green one, and there's an arrow right next to it so that I don't miss it. There you go. All right, so the study, the results of which I'm going to talk about today, would not have happened without the support of the Foundation of Prader-Willi Research, which is very similar to the research organization here which has sponsored this conference today. So thank you all for supporting clinicians like us do the research that we do. So, unfortunately, for the general practitioner around the world, right, Prader-Willi syndrome is very typecast, right? So we are used to seeing like snippets in exams and questions that come up in our board exams to basically check off, is this Prader-Willi syndrome versus 4 other rare conditions. And what all physicians basically know is that Prader-Willi syndrome can cause folks to be overweight, they have small phalanges, they're short of height, they're hypotonic, they have this insatiable hunger, food seeking, and they can have aggression. And you do a genetic test, and lo and behold, there's a paternal imprinting, 15th chromosome, and that's it, you have your diagnosis. But that's it. This is the extent of what your doctors know, right? That's it. We need to do a lot more. I'm not going to go into the genetics. You all know that already. I want to highlight today the fact that aggression, self-injurious behavior, and other behavioral problems cause the most caregiver burden in folks with Prader-Willi syndrome. How many of you would agree with that statement? All right, very good. How many of you here are caregivers? All right, so I would say about 80% of the caregivers have already experienced this difficulty, right? What's highlighted here is from a questionnaire which was done a few years ago. More recently, people just were asked to kind of type out, in a large forum in a recent Prader-Willi Syndrome Association conference, what is the biggest issue hurting their loved one. And as you can see, skin picking, tantrums, you name it, anxiety, anxiousness, it's all full of behavioral problems. In fact, you will have to search to find hyperphagia and food seeking on the screen. Okay? As one of my patients very astutely pointed out to me, Dr. Singh, I already know what takes care of hyperphagia. What is it? It's the lock. All right, so as long as you have very, sort of Fort Knox style food security in place, food seeking becomes less of a problem, but then behavioral problems are still there. So why Guanfacine? How many of you have heard of Guanfacine? Okay, very good. Okay, so people are coming in a little prepared, and that's because I've been harping on it for the last 10 years. But still, how many of you have loved ones who are on Guanfacine? Yeah, so that's the problem here, and hopefully we'll solve it today, okay? After today's talk, please make sure that you go home remembering that Guanfacine should be first line for behavioral problems in Prader-Willi syndrome. Okay, and I'll tell you why. It's very simple, right? you have someone who will start having behavioral problems, say, at, in their preteens, most commonly, 10, 11, you have significant behavioral problems. You're like, okay, aggression starting to show up. What are you going to do? You're going to go to your GP, you're going to go to your psychiatrist, and they're going to prescribe an antipsychotic, because that is considered first line in anyone with autism, because the study is done in the United States. That is, the problem there is that then they will remain on that antipsychotic for the rest of their life, okay? No problems with antipsychotics. They are useful medicines and they have an important place. But what can you do to reduce the dosage of the antipsychotic and the chances that your child will go on the antipsychotic and delay that phase before which you have to start antipsychotics? That's where guanfacine is the answer, okay? It's not for everyone, as I'll explain today. So guanfacine is a selective alpha-2 adrenoceptor agonist, right? So it's a central sympatholytic, right? So, it acts, directly in the brain to reduce the stress type of responses that people experience. It also moderates the dorsolateral prefrontal cortex, right? So we've heard already today in our talks many comments about the frontal part of the brain and its importance, and guanfacine tends to increase its activity. It's already ADHD, it's very commonly used for ADHD. So your, next door psychiatrist, which I've heard there are very few of in Australia, and it's very disappointing to hear actually. But all psychiatrists know about guanfacine. Somehow psychiatrists themselves don't prescribe it as much, although it's, very easy to prescribe and very safe to give. It has also been shown to reduce ADHD symptoms and impulsivity in folks with autism. And the most common side effect, as you might already know, is sedation, tiredness, fatigue. So I first, my first patient with Prader-Willi syndrome was back in 2014. Was my first patient with PWS, so that's almost 10 years ago now. And she came in, she had skin picking, she was already on an antipsychotic. Actually, no, she was not on an antipsychotic, she was on an antidepressant, which had caused her to develop manic features at slightly higher dosages, so it was kept at a very low dose. So I wanted to find something that I can give to her without causing significant weight, because she was morbidly obese already. So I wanted to give her something for her aggression, and I went down the list. I didn't want to give her stimulants, because stimulants can cause worsening of skin picking in some patients. I didn't want to give her antipsychotics, because that can worsen her weight gain. She was already on an SSRI, and she had a history of developing manic or psychotic symptoms at higher doses of the SSRI. So I went, just like any other good physician should, I went on PubMed. I was like, Prader-Willi syndrome, treatment, nothing, right? And then I was like, okay, what about guanfacine? Because I had used guanfacine for folks with aggression with ADHD. Nothing in PWS. So that was my first patient and my first research report. All right. Fast forward, I've done a case series on that. And then with the support of FPWR, we conducted this randomized, double-blind, placebo-controlled clinical trial with an open-label extension. I'll tell you more about that. We enrolled folks 6 to 36 years old with PWS with moderate to severe aggression or self-injury. Self-injury here was skin picking or rectal picking, just so you know, okay? We did a bunch of assessments to look at improvements or the state of their aggression or self-injury. I'm going to go back just for a second. I wanted to point out the self-injury trauma scale. That's not another thing that is not very utilized, and it should be by clinicians, right? We always kind of wonder, how are we assessing skin picking? How do you know if it's getting better or worse? The self-injury trauma scale is free, it's available, it's a very old scale, and you should take advantage of that. That's just a side note for the clinicians here. So we gave folks GXR, guanfacine extended release, or placebo for 8 weeks. And then if all of them, whoever completed that phase, agreed to go into the open label extension phase. So everyone had an opportunity. This gives an overall sense. I'll have to. So as you can see, it's still a small study, right? Only 12 patients completed the study, but it was equally distributed. And as you can see, there was no difference in the placebo or versus the guanfacine arm when it came to any demographic measures. The only adverse effect that was noted was, we looked at all the, adverse effects. What's highlighted here? Okay, yes, I can't see from here. Yeah, so fatigue was the only thing that was significantly noted reported by folks with who were on GXR versus placebo. Now, this is the key site here, right? Now, so at index visit, so we want to make sure that there was no differences between the group, and there was no difference between the two groups at index visit. So they were both, the GXR group versus the placebo group were equally aggressive or had equal incidents of skin picking. Now, this is the result slide. Everything in green, I want to point out, as you can see, aggression, hyperactivity, irritability, all improved with GXR. The MOA scale is a modified overt aggression scale. As you can see, there was significant difference in the guanfacine group versus the placebo group. The ABC scale is the aberrant behavioral scale. And as you can see, even overall, it trended towards improvement, but definite improvement with the subscales with non-compliance, hyperactivity. CGI scale showed an improvement, which is the Clinical Global Improvement Scale. MOAS showed an improvement. And then self-injury trauma, there was a trend towards improvement with the drug versus placebo. So that's the bottom line. Now, here's the interesting aspect. Although reports of fatigue was higher in the guanfacine group versus the placebo group, the Epworth Sleepiness Scale, which is an objective scale to look at fatigue, was not different between the two groups. And that's close to my clinical experience with folks with PWS, where over time the fatigue is, for most people, no different. For those who have extreme fatigue with guanfacine, which we didn't have any of those in the study, they simply cannot tolerate the medicine. But that's a very small group, and you'll know kind of within weeks that that's the case. So what's the conclusion? GXR was more effective than placebo in reducing aberrant behaviors associated with PWS, hyperactivity, and non-compliance. And aggressive behavior was significantly reduced by GXR. Skin picking, rectal picking trended towards improvement. And despite fatigue being the most commonly reported symptom, daytime sleepiness and lethargy measures were no different. Anecdotally, just so you know, a couple of patients who did not do well, they ended up on Risperdal, and they had psychotic features longer, on further assessment. So if someone has psychosis, and that was something that we had shown in our case series previously as well, they are not good candidates for guanfacine. So there's just an example of how, just sort of like a visible example of transition that can happen, or improvement in skin picking. And again, aggression, it can be life-changing for many patients. And thank you for your attention. For many people have come up asking about, more information. A lot of the stuff that I say on stage, is written right there in that book. This is my team. We are one of the research, one of the click slide, sites, and FPWR sort of registered sort of a research center in New York. Thank you for your attention. I just wanted to point out an interesting sort of discovery I made while I was writing this paper. This is the only double-blind placebo-controlled trial ever conducted for any psychiatric medication for any behavioral treatment in Prader-Willi syndrome. which was very disappointing. Very, very disappointing given how painful it is for families. So we need to do a lot more. I know we've discussed so many future things and so many things that will change the world in PWS in the future, but we already have effective treatments. We should bring them to our patients. Thank you.
Just before you take a seat, it was a nice, sharp presentation. So we have time for questions. But I just want to emphasise, I don't think you emphasised the novelty of your study. I mean, Guanfacine might be used in clinical practice, but there really is a lack of data, not just for Prader-Willi, but across other conditions. So it's a really great study. Yeah.
Thank you, Deepan, and thank you for doing the first double-blind placebo-controlled trial because, as you said, there is nothing. So for those in the room I haven't met yet, my name's Marissa. I'm a psychiatrist. I work in the New South Wales Prader-Willi clinic based out of RPA. I very much like the idea of Guanfacine, but we have some issues with Australia and accessing Guanfacine. And I saw some of the paediatricians in the room and psychiatrists in the room kind of nodding along, is it's not something you can get. Unfortunately, unlike things like risperidone, you can't get Guanfacine from your GP. It can only come from a paediatrician or a psychiatrist. And as I've heard from many, many people over the last 24 hours, how impossible it is to see a psychiatrist for adults with Prader-Willi, that's a really big kind of stumbling block. The other thing is in Australia, Guanfacine is only approved for ADHD that's been diagnosed between the age of, I think, 4 and 17. It's not approved for any other indication. Now, we do use it off-label, but it means that it can be quite expensive compared to PBS medications. And so people who are on disability support pensions on the NDIS may not necessarily be able to afford, I think it's $120 a month. Compared to the $6 a month that would risperidone would cost. So I think all of these things are worth discussing with your specialists if you can. But yeah, I just wanted to explain to Deepan why it's something that doesn't seem to be prescribed very much here, and it's because our government kind of has limited that. It also was only approved in Australia in 2018, so we haven't had it that long. So I think a lot of psychiatrists know about it, but don't necessarily have a lot of experience in prescribing it.
Yeah, and the fact is that even in the US, where it's been around for a lot longer, people don't really think of that as first line because they're just like kind of hardwired to prescribe risperidone, which is, unfortunate. There are, some hacks, so most patients with PWS will qualify for a diagnosis of ADHD. So despite some people not liking the diagnosis of ADHD, please take advantage of that fact, right? Diagnose ADHD because they will meet clinical diagnosis, and then you can get the Guanfacine. And I think you start seeing patients once they turn 12, right?
Yes.
So until 12, the pediatricians, and then Marissa.
Well, I mean, my approach is that I now write Prader-Willi syndrome and then what genetic mutation they have with OCD-like features, with ADHD-like features, with ASD-like features. And then suddenly the PBS lets you have all the medications you want.
There you go. There's a question from back there if we have time for more.
Yeah, it works now. Thank you for the nice presentation. I'm just wondering for how long this RCT has been conducted, and have you reported any adverse effects, especially those important for Prader-Willi, like hallucination and weight gain, because weight gain, again, it's important, because I think there are many reports, especially for children, for Guanfacine, weight gain and hallucination.
Oh, really? No, none, zero. So and that was actually in, I don't know if I can go back to that. If you see the, shucks, let's see, outcome measures, whatever's index. Okay, so basically we didn't find any differences between the two groups. It didn't cause weight loss, but it did not cause weight gain, and it did not cause any hallucinations or any severe psychiatric side events. So this was a 16-week trial, 8 weeks, phase 1, placebo-controlled, and 8 weeks open-label extension. Yeah. And then while you're turning that on, just like a point of note for Marissa and other clinicians. So in the study, we only went up to 4 milligrams, but in reality, I go up to 7 milligrams pretty safely. You just have to kind of go low and slow.
Hi, my name is Kate Milner, developmental paediatrician from Melbourne. I guess I just, obviously as developmental and general paediatricians in Australia, we use quite a lot of Guanfacine, as you said, in ADHD. I'm interested by the relative, like in a small sample size, the low numbers of, like the relatively low prevalence of sedation you saw. Mm-hmm. And I guess we're particularly cautious potentially in a Prader-Willi population regarding sedation and impact on sleep-disordered breathing. So I wondered if you could just speak to any adjustments you make in your prescribing practice to account for that in PWS patients.
Sure, yeah. So now remember, this was a very aggressive, increase, even going from, within 8 weeks, we wanted to get them up there. And most patients were on a stable dose of around 3 milligrams. And which is, in clinical practice, in my practice, I might have gone even higher if I wasn't restricted by the protocol, right? So in real practice, you would start at 1, maybe stay there for 1 to 2 weeks, go up to 2, and then 2 is the minimum effective dose that I've found. I don't start at, like some people start at 2-3 milligrams, and they're, patients are really knocked out. And then at that time, so it has a half-life, so basically 4 days is what it takes for it to reach steady state. So within 1 week, the sedation should go down significantly. Now they have premorbid sedation, so you need to have a good sense of how sedated they are to begin with, how much daytime sleepiness they have, because you don't want to, it's not going to improve the daytime sleepiness from baseline. So if there's a lot of, and then when I go up to 2 or 3, and if there's worsening sedation, instead of stopping it, I go down to 2. And over time, they are able to tolerate a higher dose if needed. And that helps me not give them an antipsychotic that early in their stage, in their development. Do we have time? No. All right. Okay. Thank you.
Thanks very much. We don't have enough time, I'm sorry. Thank you. If you'd like to ask questions after, please do so.